We'll do a brief overview about maternal mortality and morbidity data here in Texas, and I have some new information that I'll be providing to you. As our next step, we'll talk about evidence-based strategies that can work. They can actually, that have been demonstrated to reduce maternal mortality. There are a lot of wonderful programs that are available. There are a number who have demonstrated reductions in severe complications and in maternal death, so we'll go over those. And then finally, we'll wrap up talking about collaboration, the work that is currently being done and the ways the different organizations are able to work together. First, we're going to look at our maternal mortality data. The maternal mortality ratio, often referred to as the maternal mortality rate, has risen in Texas as it has in the United States as a whole since 2005. Here on this slide, you see Texas represented in orange and the United States represented in blue. Last summer, in the journal Obstetrics and Gynecology, which is the major publication for our OB-GYN profession, there was a report talking about the significant rise in maternal mortality. And since that time, there has really been increasing public awareness of the issues that we face. I would like to clarify some important information. The figures that you see here are taken solely from vital statistics information. And while we all strive to ensure that the information reported on the death certificates that we all certify is absolutely correct, there are some limitations in that vital statistics data. And so I think we need to be able to take this data with a grain of salt as we work to improve the data that we have available to us. One of the purposes of the maternal mortality task force is to do a detailed case review so that we can confirm the information that we have from our vital statistics data. We have talked about the fact that there are important disparities in maternal mortality. You can see here the maternal mortality ratio for African American women in orange and for the overall rate for the state of Texas there in the dashed line. African American women are at significantly increased risk for maternal mortality. They're about 2 to 3 times more likely to suffer a maternal death. The other thing that I want you to note here on the slide looking at the disparity is that while the rates have been rising for all women, the rates have been rising faster for African American women. The task force is aggressively pursuing those detailed medical record reviews, and we are working to complete those as rapidly as possible. In the absence of being able to give you a complete set for a year of those detailed reviews, one of the things that we can do to better understand specific contributing factors to maternal mortality is to look at the causes of death on death certificates. There is a strategy that has been developed by the Office of Program Decision Support that really has allowed us to identify more accurately the pregnancies or the cases of maternal death that are happening here in Texas. And that special methodology involves a matching process that matches a woman's death certificate to fetal or infant birth and death certificate so that we can confirm that those women, in fact, have recently had a pregnancy. The maternal mortality rate that I showed you earlier on the first slide comparing Texas and the United States is a comparison that looks at 42 days. That's the standard World Health Organization definition. We're comparing apples to apples, and you saw Texas was higher than the overall rate in the United States. 42-day definition. Next, the next data that we're going to look at involves deaths that go out to a full year after the end of the pregnancy. And you might say, Lisa, why do we look at a full year after the end of pregnancy? Well, the CDC has addressed this issue, and they feel that it's really important to identify all of the deaths within that year period. And then when you're doing detailed case reviews or detailed analyses, you can really dig deep and identify specific cases that are in fact related to the pregnancy. Cases that where if the woman had not been pregnant, she would not have died. So a case that's related to pregnancy is that it was the pregnancy or factors related to the pregnancy that in fact caused her death. So I want you to be aware of some of these definitions, okay, as we go to this next slide. What I'm going to show you is the top causes of death during or up to a year after the end of pregnancy for all causes. So these are not yet drilled down to causes specifically related to pregnancy, but in the broader context, the context in which these women live. So what you'll see, this is data from 2012 through 2015. Again, during pregnancy or a year following pregnancy, these are all confirmed deaths by the specialized matching process that we have, that the state has developed. You can see that drug overdose deaths were the leading contributor at about 17%. If you'll remember, in the prior report that was released by the task force last year, using data from 2011 and 2012, drug overdose was the second leading cause. Here in Texas, just as we have nationwide, we've seen a significant increase in those drug-related deaths. Our second leading cause, cardiac events, followed by homicide, suicide, infection, sepsis, cerebrovascular events, DIC or hemorrhage, other non-obstetric causes, and then high blood pressure and eclampsia causes. So again, very important. These are deaths that have occurred during pregnancy or within a year after the end of pregnancy. Next, what we wanted to be able to do in thinking about the folks that we have here in the room, the work that we're going to be trying to accomplish today, both from the broader public health perspective, but also more specifically looking at the period of prenatal care and pregnancy as well. What we were trying to do was identify, using this vital statistics data, causes that are more likely to be, in fact, related to pregnancy. So the way that we have chosen to do that is to take the information on the deaths and really focus into pregnancy and the first 7 days postpartum. So again, this is our marker for deaths that might occur in that initial hospitalization or during the pregnancy, allowing us to focus and allowing our hospital-based partners, our physicians who are working in labor and delivery, to identify areas that they can really target. So what we see here, within the first 7 days, the leading cause is DIC or hemorrhage. Second leading cause, cardiac events, amniotic fluid embolism, cerebrovascular events, the hypertensive diseases, and then pulmonary embolus. So I'm sure when you were thinking about maternal mortality, these are probably the things that you were thinking about, the immediate things that we see in labor and delivery. But again, I think it's important for us to remember the broader context in which these women live and the problems that these women face every single day. The health of a woman before she steps into that pregnancy or when she starts that pregnancy is incredibly important and contributes in a significant way to the outcomes of that subsequent pregnancy. So we need to be sure that we are thinking about those two things. As Milton Kotelchek said, you can't cure a lifetime of ills in 9 months of pregnancy. So we really need to be thinking not just on this brief interval, but also in the broader context. So we've been talking about maternal death. What we know is that maternal morbidity is about 50 times more common. So for every maternal death that you see, an estimate is that about 50 women have suffered a severe complication. So really, maternal death is the tip of the iceberg, and there are far broader numbers of women who have severe complications that need to be addressed. So what we're going to do is going to take a look at that severe maternal morbidity. Now, there are specific definitions that are used to identify cases of severe maternal morbidity. And you might say, well, what is an example of severe maternal morbidity? This includes things like the need for mechanical ventilation or tracheostomy. This includes hysterectomy, includes acute renal failure, includes a number of those very severe complications. And so when we look at that, what we've identified is a rate for Texas that's about 19.5 per thousand, or 190 per 10,000 cases. So how does that compare to the rest of the United States? If we look at the U.S. as a whole, the United States is about at 14 or 140 per 10,000 cases. So Texas is significantly increased over the national rate in terms of severe maternal morbidity. The leading cause of severe maternal morbidity, you can see there, is hemorrhage, DIC, cardiac events. Hysterectomy is one of the leading factors in severe maternal morbidity, and then eclampsia or seizures due to preeclampsia. So when we look at the contributions of high blood pressure, so we talked about hemorrhage as the leading cause of severe maternal morbidity, and blood transfusions really drive the rates of severe maternal morbidity. So here in this slide, we have illustrated the contribution of hypertensive diseases along with the other major factors that are identified as severe maternal morbidity. So hypertension is clearly also a very important complication. Now, I feel like I've given you a lot of data that's distressing. And again, this is the group that solves the problem. So I think it's really important that we emphasize that this is preventable. A lot of what we're talking about this morning is preventable. And I love this slide. I was talking about this slide at our task force meeting yesterday. This is an important slide that looks at preventability. So not every cause is equally preventable, but some causes like preeclampsia or eclampsia, the high blood pressure pregnancy, that is in these particular cases, as reviewed by California's maternal mortality review, those cases are believed to be basically preventable deaths. And as you can see here, we have other great opportunities for improvement. Obstetric hemorrhage cases in this review, 95% of those were deemed to be preventable. Amniotic fluid embolism, a little bit more complicated, right? It's a sudden catastrophic event that we do not yet fully understand. Many of those deaths may not, in fact, be preventable. But again, this, I think, gives us hope that we have interventions that can be effective in preventing these maternal deaths, and I think we need to act. So, protocols and checklists. There are a number of different, we're not the first people to recognize this problem, right? And there have been a number of interventions that have been developed nationwide that we can implement here in Texas. And protocols and checklists across a wide variety of fields, right? We talk about the airline industry, for example, the military. The use of protocols help us perform critical tasks the same way over and over, reducing variability and reducing the opportunity for error. These types of checklists, protocols really can help us reduce adverse outcome. One of the first things I'd like to talk to you about, we talked about hemorrhage as one of the leading causes of severe maternal morbidity here in Texas. So let's talk about what can we do with hemorrhage. This is data taken from Elliott Main. Elliott Main is an obstetrician gynecologist who leads the California Perinatal Quality Collaborative. And what Dr. Main did was take a bundle, a group of interventions that had been developed by the Alliance for Innovation on Maternal Health, and implemented those within their Perinatal Quality Collaborative, which brings together hundreds of hospitals across the state of California. And when they were able to test the implementation and the effectiveness of these bundles, they had an intervention group where the hospitals put this hemorrhage bundle into practice, and they had a group of control hospitals that did not put the intervention into practice. And this is what they found. They found a significant reduction in morbidity from hemorrhage at the hospitals who implemented the bundle. So this implementation was able to move the dial on complications due to maternal hemorrhage. Let's look at hypertension. There have been a number of bundles and other interventions that have been developed to address hypertension. We noted that hypertension is one of the leading causes of maternal complications for us, and these complications also disproportionately affect African American women, so they're particularly important for us to address. This is data taken from now one of my partners, Dr. Steve Clark, when he was working for the Hospital Corporation of America. And what they did was institute a very specific protocol for the management of high blood pressure in labor and delivery. And they were aiming at the identification of that hypertension and treatment within 30 minutes of the identification of elevated blood pressures. And what they wanted to do was to decrease the amount of time that women had severe hypertension. And what they did with this implementation of this process across their many hospitals all throughout the United States was have a significant reduction, and this is actually in deaths. Because their hospital system was so large, they were able to show that the implementation of these specific orders, these specific protocols within their hospital reduced maternal death. The Alliance for Innovation on Maternal Health has a goal of eliminating preventable maternal mortality. The Alliance is a very broad group of partners, a very broad group, just like the group of people that we have put together here today, coming together and saying, okay, this is a major problem. We're all here. We want to work together. How do we put our expertise together to identify solutions? They provide tools that can be implemented across a wide variety of hospital systems, whether you're a level 1 hospital or a level 4 quaternary referral center. The information that is provided is applicable to everyone. The Alliance for Innovation on Maternal Health provides implementation training. Many of us have not previously implemented quality initiatives, so this group will provide the how to do this. Real-time data is a cornerstone, right? If something's important, you get the data and you track it. And you use that data to evaluate the impact of your intervention, the effectiveness of your intervention, and then you're able to continue that next cycle, okay, based on our new data. What do we do next? Okay, based on our new data, what do we do next? So it provides real-time data and builds on existing initiatives that are already happening. There are 4 domains of these bundles. You know, I've talked about this with physicians before, and usually the first thing people say is, Lisa, I don't want you to tell me what to do. You know, as physicians, right, we've spent our entire medical training learning how to evaluate our patients and make a plan based on that situation. I want you to know that these bundles provide you with guidance, and they don't tell you specifically exactly to give 100 milligrams of labetalol. It's not like that. These bundles really help you address 4 very important domains: readiness, recognition and prevention, response, and reporting systems and learning. So it's not a cookie cutter solution. What many states who have implemented these bundles have done is they develop their own toolkits for implementation, understanding their own systems, so that they can be successful in making this work in their individual locations. There are toolkits that are available for implementation of hemorrhage bundles, for example, that have been made by California's Quality Collaborative. There are different toolkits that have been made by Florida's Perinatal Quality Collaborative, as both of them implemented these types of programs. So these bundles don't tell you exactly what to do, but they provide you with a framework that you can use to implement these solutions within your facilities. And resources are available, tools are available if you want to use them. Do you want for example, in the recognition and prevention section for the hemorrhage bundle, we'll just talk about that. In the recognition section of the hemorrhage bundle, they provide resources. There's a screening tool that you may choose that's pre-made that you may choose to use at your facility to identify women who are at higher risk for hemorrhage and have those women receive perhaps specialized attention. There are a lot of tools that are available to you so that you can implement these bundles. So what's available? What's already out there? Let's not do work that's been done before. So there are safety bundles that are available on obstetric hemorrhage, hypertension, prevention for venous thromboembolism or blood clots, patient safety, safe reduction of the primary cesarean delivery. But then there are also safety tools that are available, and as you can see, there's case review forms so that at your hospital you could review cases of severe complications to help you understand locally what's happening. And then there are other resources. There's a bundle that was developed on reducing disparities in maternal care. So lots of things have already been developed. Most recently, within the last month, a bundle was put out looking at obstetric care for women with opioid dependence. So there's, as I said, we're not the first to recognize the problem. There are a lot of solutions that exist, and we have an opportunity to take advantage of work that's already been done. The Alliance for Innovation in Maternal Health has received a grant from HRSA to implement these bundles nationwide. Right now, there are actually 12 AIM states, and you can see I had previously mentioned California and Florida as states that are implementing bundles to reduce maternal complications. Again, we are incredibly fortunate in this state to have a number of groups who are already working together to address this problem. You all are aware of the task force. We've talked about that a little bit today, and really the charge of the task force is to focus on the data, the analysis, reporting, and making recommendations to reduce maternal death here in Texas. The Perinatal Advisory Committee, HHSC's Perinatal Advisory Committee, has been focusing for the last several years on ensuring that we have rules in place that ensure hospitals are designated with a particular level of care that they can provide. And I will admit it's a little bit awkward to be talking about the incredible work of the task force. I see Dr. Emily Briggs out here and a number of other members of the task force, and the incredible work that their leadership has provided has really given us an opportunity to make sure that our patients get the right care in the right place at the right time. It ensures that hospitals have the right resources to care for whether it's babies or care for mothers, so that they get the very best care in each institution. The Texas Collaborative for Healthy Mothers and Babies is our perinatal quality collaborative. I've talked about them a little bit this morning, and I'm so grateful to Dr. Lakey for leading that. This is an amazing opportunity to bring together and to coordinate improvement efforts across our state, and taking recommendations or ideas that they see from a broad number of groups, including the Maternal Mortality Morbidity Task Force, including the Perinatal Advisory Council, and taking those recommendations and making them real, turning them into projects that occur across our state to improve maternal health. Finally, I just want to mention the Healthy Texas Women Program. For women who are enrolled in the Medicaid program and lose their Medicaid following their deliveries, they are automatically enrolled in this state program that provides them with services to address problems such as chronic hypertension and diabetes, and also provides a significant number of the full variety of family planning resources for women who are enrolled in the program. So we have a number of different organizations working together. The task force looking at your data and analyzing the data, the Perinatal Advisory Council ensuring that our hospitals are appropriately designated with the level of care that they can provide, the collaborative implementing evidence-based solutions, and then Healthy Texas Women providing coverage for women across the spectrum. Again, I want to thank you all so much for sacrificing your time and giving your incredible wisdom and talent to an incredibly important problem that, again, I know we can solve because we have the right people in the room. So thank you.